Good morning, everyone, and thanks so much, Mairead and Gillian, for that introduction and for inviting me here. The last time I was in Ireland was in 2001, almost 25 years ago, and in that time, I understand you've got a lot richer. GDP per capita has tripled. I was then a young doctor working in the NHS in the United Kingdom, and I came over for some respite. And I hadn't done any research then. I started my research career the next year, and I hadn't started my public health or global health career. I was still a clinician. So it is a real pleasure to be here today with you. I'm sorry that I missed yesterday's great sessions, and it seemed like there were discussions on topics close to my heart, like embedded implementation research. I'm glad that other people talk about that. We do a lot of that. Genomics, artificial intelligence, emerging global health threats. So I'm very sad to have missed that. But at the same time, I was privileged to join the dinner last night, and I chose the right table to sit at, a group of immunologists. You wouldn't think they'd have that much in common with me, but it was a great discussion, and I was pleased to see that despite how much richer you've got, the Irish love of a good chat, aided by a good drink, the craic, I suppose, has persisted. So that is reassuring in these times of change. It's particularly nice to be here with all of you today, because in my world of global health, it does seem like things are falling apart. And I know that there are different views on Yeats these days in Ireland. Sally Rooney apparently hates Yeats and thinks he's a horrible man and really is offended by the idea that he's a symbol of Irish literature. Now, I'm not going to disagree with her. I mean, it seems to me that she's now the symbol of literary Irishness, and I never met Yeats, so I'll take her word for it. But I hope she'll forgive me, and you'll forgive me if I reflect that Yeats's words from The Second Coming, that things fall apart, the centre cannot hold, that the best lack all conviction, and the worst are full of passionate intensity, sadly seem very opposite in my world. And earlier this week in Geneva, we just concluded the executive board of the World Health Organization, and my discussions with country delegations were very grim. For example, my South African friend said to me that they're now trying to work out how to fill a $400 million gap in their health system that funds their HIV program, that employs almost 15,000 workers, mostly women, mostly at community level. And they really have no solution for that. And if they don't find a solution, or if things don't change, a lot of people are going to die. So that is very grim. So it does seem perhaps like the end of an era in global health and in global solidarity, which very much started around the time that I last came to Ireland. Probably this era of global health started in January 2000, with the formation of the Global Alliance on Vaccines and Immunization in January of that year, and then was accelerated in September 2000, when all of the leaders of the world gathered in New York at the UN General Assembly and adopted the Millennium Declaration, which paved the way for the Millennium Development Goals and the commitments of the world for reductions in poverty, improvements in education, but in health, targets on HIV, TB, malaria, child mortality, maternal mortality, and really fueled tremendous progress, because we have seen tremendous progress in global health over the last 25 years. So what I'd like to do, and I won't talk any more about Ireland because I know very little about Ireland, but hopefully some of what I will say will resonate with you, is to reflect on that 25-year period, on those tremendous achievements in improving health, and the role that science and research has played in those achievements. And then what I'd like to do is reflect on the changes we see in the world now and the stress that health systems everywhere are under, and consider whether health systems are able to react to address those threats, and then finish with this community of scientists and researchers and think, how are we assisting health and social care systems to respond to those threats? And the question I posed, are we fit for purpose to do so? And then I'll finish a little bit with what we at the Alliance for Health Policy and Systems Research and at the World Health Organization are doing to try to meet this challenge. Because I'm sure all of us in this room believe that science and research is essential for the innovation, for the improving efficiency, but most of all for realizing equity. I think we can still say that word in this room, I hope, that is required to drive health improvement and human progress, but that is not assured, and science and research does not necessarily lead to that. So how do we design our systems of learning? How do we act to give us the best chance of doing so? And that's the questions I really have, and I hope you will have all of the answers. So we've absolutely had 25 years of tremendous progress in global health. And so despite my slightly grim invocation of Yeats to start this off, we should be very proud of that and reflect on that. The world has moved tremendously in health over the last quarter century. Life expectancy has improved dramatically, and to take, one country I know well and one country I know less well. So Ethiopia and Rwanda in the 2010s, that decade, life expectancy improved by 5 years. That's as fast as life expectancy has improved anywhere in the world in human history, right? Those countries have a lot of challenges. Those countries in that period had GDP per capita of about $1,000 per capita, US dollars. That's a hundredth of GDP in Ireland today, right? A hundredth. That is astounding to me. Again, I'm still surprised. And alongside with that, we also, and linked to that, we saw dramatic reductions in child mortality. So in 2000, about 10 million children died every year under the age of 5 of preventable causes. And now it's less than 5 million, about 4.5 million children die. Still far too many, but that is dramatic progress, right? Of course, the HIV epidemic, in 2000, millions of people had no access to treatment. Millions of people were dying. Life expectancy in a number of countries in Southern Africa had plummeted in the 90s. Because of the mass epidemic, and there seemed little hope that those people would access treatment. And yet, through science, but also linked to politics and activism and social movements, those people today do have access to those medicines. We still have a long way to go with the epidemic, but a lot less people die, there are a lot less infections, and that's why it's so grim that progress is in peril today, and that we could catastrophically go backwards very quickly. The area that I know best, that I've worked on in different lenses, as Mairead said, is immunisation, right? So I started my public health career as a co-principal investigator for meningococcal B vaccine trials, outer-membrane vesicle vaccines for the immunologists. And then I've also worked a lot on implementation research on how do we deliver vaccines. And then now we do a lot of work on vaccine uptake. How do we have trust? There's a huge challenge of anti-vaxxers in all countries now. But to reflect on that, I mean, when I was in Cambodia most recently, and Cambodia has 95% coverage of basic immunizations of EPI. Again, in a country with about a GDP per capita of $1,500 per person, which is tremendous. Cambodia is the 5th most vaccinated country in the world for COVID vaccination. So, and that really has been accelerated by a coalition of new vaccines, the impact of Hib, of rotavirus vaccine, of pneumococcal vaccine, but also linked to supply chains, delivery mechanisms, the ability to deliver, to bridge that no-do gap that we talk a lot about. And I think that's an example in immunization that we need all branches of science. We often balkanize ourselves into basic researchers and clinical researchers, and less of us who do policy research or implementation research. But for people to benefit at scale, for there to be greater equity, we need all of us together. Now, that doesn't mean we all need to do everything. We do need specialization. We need the ability to be good at what we do. But we do need to be able to come together and understand how we contribute. So it has been, as I say, this time of tremendous progress, and science has contributed so much, and science has been able to be distributed. The science systems in countries have improved so much. So in the countries we work in, 25 years ago, there weren't necessarily the ability to do clinical trials or to do implementation research. At the beginning of the pandemic in Cambodia in January 2020, when we had the first report, we had in Cambodia a lab, Pasteur, that could very rapidly test for COVID. In fact, I think we were able to start testing well before the United States because they made a few mistakes there, which is a tremendous achievement around science systems in a country like Cambodia. We had 3,000 workers, mostly at primary care level, trained in field epidemiology. So we could do outbreak control and outbreak management. Those are great assets that have been built over the last 25 years, and countries lead and can take the credit for that. But the world has contributed to that. Those workers were trained by WHO and US CDC. That lab, Pasteur, has benefited greatly from being part of the Pasteur network and a lot of support from the French government. So these are the achievements of global solidarity. And at the beginning of the pandemic, there were articles in the New York Times saying, why isn't COVID worse in countries like Cambodia? I mean, they didn't talk to anyone in Cambodia when they had those articles. They talked to people in Boston and Washington. But anyway, Cambodia was able to minimize death, and the health system was not overwhelmed. So those are the achievements that we've managed as a world together over the last 25 years. But those achievements are very much at threat. So we had this experience of COVID, which of course was a horrific pandemic, which has transformed all of our lives. We still see the social and economic consequences of COVID in all countries, I'm sure even in Ireland, and those consequences will continue for a generation. So what we see also in health is reverses that we never thought we would see. So global life expectancy fell for the first time in 2020 and 2021, perhaps understandable with a pandemic. But we also saw reverses, for example, in global immunization coverage, which was a trend that had been improving for the previous 3 decades. We saw disruption to health services all over the world. But even worse, we saw a real fragmentation and deterioration of people's trust in health systems, of people's trust in science, people's trust in all of us. And I think that's something we need to take very seriously. In terms of funding for health systems, the most recent WHO database for global health expenditure, the report from last year shows, again, for the first time in a generation, domestic financing for health in countries per capita falling, at countries of all income level. You might say, well, that's understandable after COVID. But in a world that's trying to reach universal health coverage for everyone, it's shocking. And then, of course, even before the events of the last month, we have seen a dramatic decline in global assistance for health, which peaked during COVID at around in the 60 billion range. Now, that does seem like a lot of money, but let's remember that the global health sector is a 9 trillion plus sector. the vast majority of money that is spent in health, even the lowest income countries, comes from those countries themselves. But that global money is very important catalytically. It's often very important for the most marginalized groups and countries. So that is declining. That was already down probably into the 30 billion range this year. And all signs, not just in one country, but in all countries, we're seeing aid budgets slashed. And that will go down further. So these twin forces are grim. And that's in a context of the threats we face in the world. So I know you spoke about emerging infectious disease threats yesterday. We're in a world not just still recovering from COVID. We have a Marburg outbreak in Tanzania. We have Mpox outbreaks in many countries in Africa. We have a new Ebola outbreak with Sudan virus in Uganda. Workers in Uganda, the government has written them a letter saying, we can't pay you anymore, but out of patriotism, will you continue working as volunteers? The government has no choice but to say that. But if as a world, a few years after COVID, we can't pay people in Uganda to combat Ebola, what lessons have we learnt over the last 10 years in terms of emerging threats? Climate, sorry, this part of the speech is going to be very depressing. Apologise for that. In climate, we've probably already blown past the 1.5 degree target in the Paris Agreement that the world agreed to contain the catastrophic impacts, including on health, of climate change. And we're seeing those impacts all the time. I talk to colleagues, I know the head of the National Institute of Public Health in Mozambique. I'm just name dropping here. And he doesn't have peacetime in his health system. Every day he's dealing with outbreaks. He's dealing, like say cholera. He's dealing with a civil war. He's dealing with extreme weather events, flooding, cyclones of much greater intensity. That's his daily life. It doesn't stop. That's what health systems have to deal with. The conflict. So if you look at the world, people of my generation, the 90s and the 2000s were a period when the world got more peaceful. I think the world got more peaceful in Ireland as well. If you look at the Uppsala group in Sweden, they track the number of conflicts in the world. And if you look at the graph, in 2010 there's an inflection point. And for the last decade, conflicts are on their rise. And I don't think I need to tell you that. I mean, you read the news. And so more people live in situations of conflict than ever before. There's more people who are being forcibly displaced than ever before. And they are the people in the world who experience the worst health. We're struggling with demographic change. So I think Ireland is the second youngest country in Europe. Well done for you. Does the Catholic Church have anything to do with that? I'm not sure. But I was in Japan at the end of last year. We had our board meeting there. Japan, a third of the population is over 65. Right? A third. And that is where we're all heading. By the end of the century, half of the world's children will be born in Africa. And every society, except a few countries in Africa, will be an aged society. And our health and social care systems are often struggling with the number of older people we have now and fulfilling their needs. And so we really need to change. I think underlying all of this grimness, and then I'm going to start to be more positive, I promise, is a sort of deterioration in our solidarity in our societies and globally, and that is fueled by inequality, right? Even in a country I know as wealthy as Ireland, you have increasing problems and challenges and frustrations around inequality. And I think that really thinking about the role of science in driving towards equality and not just seeing, well, that's not really our problem, is something we need to take seriously, because you cannot sustain the consensus to allow science to flourish in a divided society, or allow the progress that science can enable to be taken up, the knowledge to be used in a divided society that doesn't trust scientists. So I think inequality is very much our problem. So it is grim, and I don't think health systems really are responding as they should to all of these threats, to this rapid pace of change. I often joke that the academy and the hospital are the two most conservative institutions in our societies. In my lifetime, most other sectors have been transformed in the way we experience them. But the way that you go to the hospital and you experience care, or the way that you experience the academy, has not changed so much, and we should question why that is. There are these two forces in our society that are already upending everything, and that will just accelerate, and they're digitalization and decarbonisation. A lot of people are very skeptical about digitalization, maybe even in this room. There was a summit this week in Paris where global leaders came together, brought together Macron from France and Modi of India. And this time there was much less focus on all the risks of artificial intelligence and a much greater focus on opportunities. I think we need both. But if you look at the advances in artificial intelligence in terms of health systems over the last 2 years, they're staggering. The pace of improvement. The artificial intelligence is now able to outperform human clinicians in many fields, has been able to pass board exams in a number of countries, costs $2 a day, and an artificial intelligence is willing to work in rural areas and in difficult conditions. I feel often, I've done a lot of work with community workers delivering care in quite difficult places. And my feeling in the way that we're dealing with AI is the same resistance as doctors often have to community health workers delivering care, even when we have the evidence that they can deliver care with safety and with quality. And they say, oh, it's not safe, and there'll be antimicrobial resistance, and it's not effective, and people don't want that, and it's going to be terrible. I think the question is, how do we integrate AI into teams? In Singapore now, and in a number of other countries, they're using artificial intelligence for screening of diabetic nephropathy, diabetic retinopathy. So even Singapore doesn't have enough ophthalmologists to screen everyone effectively. So they're now using that for screening. It's much cheaper, and then they can be referred to the ophthalmologists. I mean, I'm not sure if anyone should be going into a career in radiology at the moment, right? If you look at the way the world is going. The question is, how are we able to integrate and manage the risks with governance? Because AI is going to happen. I had a conversation last year with a 26-year-old guy at OpenAI who make ChatGPT. And he has a team of people younger than him working out what they're going to do on health systems. So we have to engage with that reality and think how our science can inform that for benefit and inform the governance. Decarbonisation is similar in that if we can get energy to people who don't have it, that'll have tremendous improvements in health. The question is, how can we steer these forces towards equity and not what normally happens when we have new technologies back to inequity? And I really think health systems are struggling with their role in doing that. So what then is our role as researchers? We have much to offer, I believe. I'm sure all of you do as well. But I think we do have to change. So well, I hope not, but if a golden era of global health is coming to an end, we are in a golden era of discovery science. Right? I mean, the advancements for cancer, for diabetes, for obesity, for eczema, which I have personal experience of, is dramatic. The potential of mRNA vaccines, right? It is really dramatic. And yet, that no-do gap often seems unbridgeable. And the challenge of equity is even more telling. So when will most of the world get access to all these new therapies, which are transformational, right? So the risk is that in this golden age where the fruits of decades of molecular biology are really coming to pass, will just be kept by a very small percentage of the globe. In the same way that we saw with COVID vaccines. What an incredible achievement. 11 months from a new organism to mass immunization. When I did my randomized control trials for meningococcal vaccines, we bridged from existing data from other vaccines and from Chile and Norway. And we did these trials in 2.5 years, community-based, publicly funded. And then we went to roll out after 2.5 years. And we thought we were doing really well. But 11 months. So that shows what's possible. But we have much less developed our science of delivery, of how we can actually ensure that people benefit from that science. As I said, we remain balkanized. We talk a lot about interdisciplinary and transdisciplinary research, of mixed methods research, but the incentives in our system are not there to support it. Often that remains very rhetorical. And that doesn't mean, again, that everyone should do everything, but how do we create those bridges and those coalitions for that end-to-end type of research? We are also, I think, struggling with our own systems of communication, the proliferation of journals. The first journal paper was written in 1660. The basic format of the journal paper has not changed significantly, or the basic format of a journal. We just have a lot more of them. I had some, it's apocryphal, but I think one stat was that half the papers in human history have been written since 2009. It's impossible to keep up with all of that. We have predatory publications. We have a journal industry. I said this to Richard Horton last year. I said, we have a journal industry, which is, other than a few editors, the editors are poorly paid, the researchers aren't paid for publication, the reviewers aren't paid, and yet it's controlled by a group of companies that are some of the most highly profitable private companies on the planet. I mean, if there is a system ripe for disruption, I can't think of a system more ripe for disruption than that. And yet, our technology hasn't necessarily helped that. If any of you, I don't know how many review requests you get daily, but I get a fair few. And just the simple challenges of accepting or declining that in the different logins is so difficult, right? This is not a system that has evolved well. And often so much of our research is not well consumed. I haven't met many ministers of health in my life who read journal articles. I used to work in a Ministry of Health a long time ago for a minister who didn't read more than half a page, which meant that you ended up with me on a Friday afternoon when I wanted a beer, summarizing these huge 200-page reports. I always say to my team, please write a good summary, otherwise you end up with someone like me 20 years ago in a ministry on a Friday afternoon wanting a beer, summarizing your very earnest report. So we haven't thought enough, I think, about the way we communicate our science to reach different audiences. We're not so good at co-creating as we could be. Right? We talk about it, but researchers still remained often siloed from policymakers, from implementers, from decision makers, from communities, from clinicians. We could do a lot better. And here, the technology is very promising. I've had researchers say to me, well, I don't have time to write a policy brief because I have to write my paper. That's what's going to advance my career. Well, now there's really no excuse because you can just get ChatGPT to write your policy brief, right? Or you can even probably soon, very easily, you can do it already, do a nice little YouTube video which explains your science, right? So there's a lot of possibilities, but to take advantage of those possibilities requires us to change our internal incentives in our systems, but also change who we see as the audience for our research, and also care about creating impact. Of course, and as I'll finish with what we're doing, our strategy is called aiming for impact. Now, of course, there's no linear relationship between research and impact. It's not that simple. It's complicated. Many things have to come together to create impact. But you have to create the conditions to give yourself the best chance that your research can have impact. And do we have systems that incentivize our researchers to do that? I don't think we do. So in this context, I think that we as scientists have so much to contribute, as I say, to that necessary in innovation, efficiency, and equity, that is the only way that our health systems are going to be able to cope with all of these challenges and to address this crisis of confidence in scientific expertise and experts. But to do that, we do need to do things quite differently. And so, to finish, some of the things that we're doing at the Alliance of Health Policy and Systems Research, we don't just have a nice strategy that's called Aiming for Impact. We are doing a few things at the moment. We have a piece of work called Health Systems 2050, where we're really trying to conceive the scenarios of not just considering how health systems need to adapt to the challenges of today, but also think what health systems might look like in 20 years. And I think that is going to be dramatically different everywhere. We're also doing some work on the digitalization of research itself, which is, I think, also an area that many of us are not paying enough attention to. I was talking 2 weeks ago to a young guy at medical school at Columbia University in New York who's developed an app with AI to do systematic reviews. Right? And I was playing with it. And it really, there's a question to us, like, what methods should we be training people in? Right? Especially for me, when we think about the institutions we're supporting, where there's often not so many people, there's not so much funding. Should we still be training people for several years in a PhD to do systematic reviews? Right? Given that that might be some of the tasks. What, in terms of qualitative research, the potential to democratize that, to demystify it and make it more useful with AI is huge. Obviously, there's been a lot of talk about AI in terms of scanning potential compounds for medicinal benefit. So I do think we have to embrace that and not see it as a threat. It doesn't necessarily mean that it will replace us, but it could mean that our methods are much more accessible more broadly. It could really help to communicate what we do. So those are two pieces of work we're doing. And a lot of our work, I mean, we focus on policy research and implementation research, is really around making co-creation real. It's very hard. So we do a lot of embedded implementation research. We train people on it. But it only works by the relationships, right? I mean, it's a terrible term. What does embedded implementation research mean to most people? But that idea of co-creation does mean changing the incentives, because people prefer to work as they always have. One of the things we've done sometimes is give the research money to the policymakers or the implementers to force the researchers to engage with them. Researchers really hate that. They say, what are you doing? They don't know anything about research. They're not objective. They don't have rigor. But we're sort of forcing that marriage. And I have to say, a lot of the embedded implementation research we do doesn't live up to what it says on the tin. It's not research still happening in live systems where co-created between implementers and researchers, where the results immediately feed into course correction and change. That's the vision. But we sometimes achieve that, but we often don't. So to conclude, I'm actually quite an optimistic person. And I do think through all these disruptions and challenges, there's great opportunity. But that opportunity will only occur through a lot of hard work, through people coming together, and through us as scientists challenging ourselves to broaden who we try to reach, to not compromising on the quality of our science, because without first-class science, none of the other stuff will make a difference. But also taking seriously, as I say, that challenge of equity, that challenge of creating true innovation and impact, and also to think about how we contribute to the efficient use of resources. And I'm sure you're all up to the challenge. I mean, if Ireland can be 3 times as wealthy as you were 24 years ago, I'm sure that you have an enormous amount to contribute to addressing these challenges, not just in Ireland, but globally as well. So thank you very much.
Thank you very much indeed, Kumanan. That was absolutely fantastic. And it's good to be, because it's, you get quite depressed these days reading the news, but it's good to be reminded of the progress that we have made, I think, and just the achievements that we've made in public health, and, as you say, the assets that we've developed over the years. And I also very much liked your point about embracing or using the new technologies to drive equity. I think that's so important. And the co-creation, which we've been certainly trying to look at in the HRB to drive that end-to-end research. Okay, we've got about, I think, 10 minutes or so for questions. So I'm sure there's lots of questions from the audience, and also you can use Slido as well if you remember from yesterday. If you go in and you can use slido.com if you put in the code. So any questions? There's a roving microphone, I think, somewhere. I'll try and see. Wave at me, because there, right here, please. Yeah.
Hi, it's Chris Noon, School of Psychology, University of Galway. That was a brilliant talk. Thank you very much. you made 2 points at different stages that I think are connected, and I want to see if you think they're connected too. One was about the horrific gutting of funding for global health, and the other was you made a point around half the world's children are going to be born in Africa. I don't know when exactly you said in the future, but by the end of the century. Do you think those two things are connected by racism? Do you think that we see obviously the US government is turned significantly to the right, to the far right, and they're leading the charge in terms of defunding global health, and there are conspiracy theories around the need to basically increase the amount of white children being born, and that we know are connected to people within that government. So I'm curious about your reflections on whether those 2 points are connected, and whether we need to be stronger in health research about calling out that kind of racism.
Do you want to?
Sure.
And there's also a question there, I think,
Yes.
on do you think the legacy of colonialism has affected healthcare?
Again, as I was saying last night, it's great to be back in Ireland. It hasn't changed that much because you get straight into the difficult questions and the politics. And I'm a member of a Lancet commission on structural discrimination and racism in global health, and it's led by these two wonderful women. Taleng Mokofeng, Dr. T, who's an obstetrician from South Africa. She's also the special rapporteur on the right to health. And Ngozi Arondu, who's an epidemiologist, Nigerian-American. And we were just looking at our recommendations. I had a call this week for that. And I think it's encouraging that people are talking about these things, right? I mean, to have a question, what's the impact of colonialism on global health? I'm of Sri Lankan origin, and I joked last night that we got three versions of colonialism. We had the Portuguese, and then we had the Dutch, and then we had the British. And I understand, a little bit about colonialism in Ireland. So, clearly racism and colonialism affect health, right? And it's great that we can have that conversation. But what I was saying to my colleagues this week is that if we just have this Lancet report, and it's great that it's in Lancet, and Richard's very supportive actually, but Richard's reflected on the Lancet's own origins and its sort of ownership of colonialism itself in the 19th century and earlier on. And so, but it's great to identify those things. But I think of what's happening in the world is that you still have to be able to talk to people, right? And so if we just diagnose everyone as racist, well, what do we do with that? And I think that is the bigger challenge, right? So clearly colonialism and racism are key drivers of health inequity. I don't think anyone's going to dispute that. But then what do we do about that? I think that is the bigger challenge. And how do we bring people in? And that's not just a kumbaya thing to say. I think what we're seeing now is that if these ideas are just the domain of one part of society, and then the other part of society feels challenged, and then there's this violent counter-reaction, that is deeply destructive, right? And public health, as one of my friends, Sandra Galea, wrote after the election in the US, public health in the US, they have red and blue for the Democrats and Republicans. And he said, well, public health has to be purple. We cannot only do public health when one side, is whoever you like, is around. So how do we actually reach people and make ourselves relevant? And so I think we shouldn't forget the tremendous progress on racism and addressing colonialism that actually has happened. Now, there's a long way to go, but I come from a little village on the north of Sri Lanka. If you look in my lifetime, the opportunities and what has happened. So I think that's true, that there is this real fight of ideas. There's a violent counter-reaction to some of the measures to address racism have been implemented. But we should also consider how many of those measures have been performative. Have they really addressed the major problem? And have they sort of looked at the links between essentially the people who feel they don't have opportunities and feel left out, whoever they are, and those who do have opportunities. And I think every society, big or small, is facing that. And I think we as scientists have to consider, well, what do we have to contribute to that debate? So sure, we can describe the problem and we can have data, but are we also involved in considering the solutions? And some of that is in our role as scientists, but some of that is in our role as citizens.
Okay, lovely. Over here, Mark, I think, is it? Yeah.
Mark Lawler, Professor of Digital Health at Queen's University Belfast, but probably in relation to this, more relevant, I'm co-chair of the European Cancer Organisation's Special Network on Emergencies and Crises. I'm going to push back a little, super talk by the way, but I'm going to push back a little bit in your suggestion that global health is dead. One of the things we've been looking at, and we've just produced a manifesto that was published in Lancet just before Christmas, is looking at how do we actually support cancer patients in war and conflict zones. You may not be aware of this, but the amount of damage that the Ukrainian war and the invasion by Russia has done to cancer services. It's displaced probably 3 to 4 million cancer patients. It's looked at essentially destroying the cancer infrastructure. So one of the things we've been doing is trying to provide support, but also providing data to inform how we're going to rebuild. I feel that there's a moral imperative for us to actually do that in Ukraine, in Gaza, in South Sudan, where conflict has actually affected cancer patients. It's obviously affected other patients as well, but my area is cancer. And it's how do we do that in the context of the pressures that we're under in relation to this sort of essentially brutal attack on global health?
So just to be clear, and please don't tweet, I do not think global health is dead. I've been doing it a long time, and I'd like to do it for quite a long while longer, but we just need to be relevant. And global health will always exist in some form, but the question is it relevant, and how do we address the threats? And I completely agree with you about the role of conflict. So we do work in Ukraine at the moment. The head of the WHO office, Jano, we're doing work around service delivery. And it's a very interesting situation in Ukraine because the existing, quite a mature health system, as you know, is trying to deliver not just to respond to the acute trauma and the injuries and the deaths, but also, as you say, to persist cancer services, cardiovascular disease, and they've seen increases in stroke and cancer and alcoholism. So absolutely, and WHO had a conference last year on NCD care in non-communicable disease care in conflict situations. And we're also doing work similarly in Yemen and Somalia. So as I said, I think the world has to think about how to deliver services in conflicts much more. That's part of what I said. So completely agree with you. One of our 5 priorities is actually non-communicable diseases for the Alliance. And we're just starting some work on implementation research in 8 countries. And I think one of the failures of the MDG period globally was a neglect of non-communicable diseases, and we're very much paying the price for that. As you know, most people who die from non-communicable disease are in low and middle-income countries. So I think maybe a couple of the other questions in the time we have left. How can funding agencies disrupt the publishing model? I think Mairead is probably better equipped to say that. I mean, I believe you want to have change, you need to change systems. If you want to change systems, you need to change incentives. You need to change interests, right? And I think that is something, and people have tried different things. The Gates Foundation no longer pays open access fees, right? And they have their own repository. Wellcome is going in that direction. So there are a lot of ideas in that. It's not easy because we all like writing in journals, right? And they do a lot of good, but it's just this question of how do we make that more equitable and more useful. The easy question about Gaza. He's now doing a PhD in the UK, but I had a team member from Gaza last year, and it was very, very difficult. Members of his family died, but I will say that I think we do need to look at these things broadly. Like, we had a civil war in Sri Lanka for 30 years, and healthcare still got delivered. You have to be careful. In conflict, everyone suffers, and there's a moral hazard around when it's not you in the conflict, right? Certainly in Sri Lanka, a lot of people tried from outside, some with good intentions, some with not. It didn't necessarily help, right? So you have to be very careful intervening from outside. And again, do I need to say this in Ireland? I'm not sure, right? Because of that moral hazard.
Okay, thanks. Any other questions from the floor? Sorry, over there. Sorry, the light is in my eyes here, so I find it hard to see.
Yes.
Please, go ahead.
Hi, Ella Arendsman, School of Public Health, University College Cork and National Suicide Research Foundation. Thank you very much for an inspiring presentation, even though obviously the huge challenges that we have. We're working with WHO more than 20 years, and particularly in the area of non-communicable diseases, and we have had over 10 years annual work plans with the WHO PAHO office in the US, which very sadly is coming to an end. But we internally, we just said we have to be resilient and we have to start looking at scenarios B to get to our objectives, to our aims. That's still, everything is happening so fast, so we don't have these answers yet. But what are your views on any alternatives, scenario Bs, for example, where within the EU, but the EU with maybe the strengthened links with Asian countries, African countries, can look at alternative scenarios to continue the global work plans, and for example with the PAHO countries?
So I think there's a sort of acute crisis, right? Because this is being so sudden, and let's see how it plays out. But it was already happening, this reduction, right? And then there's the sort of long-term view. So the acute crisis, there was a question, can AI contribute in South Africa to delivering care? And people are certainly thinking about that. I mean, they were thinking, I mean, people are skeptical. But so there's going to be an acute situation of how do you continue things, right? But then there is the long term. And the long term, as I said, is that most health services are not paid for by aid, right? Aid has to be a catalyst. And we need to use this moment, in a sense, I think, to construct a new global health and think about, well, what is our role now? It's not 2000. It's 2025. I used to work in China a long time ago at Peking University. And, so China has gone through that transition, obviously, right? So China is now a huge generator of knowledge and science, and it's now supporting other countries. It's interesting, though, that a lot of the people trained in global health in China struggle because China's not necessarily investing in global health research in their own country. They're still hoping that will be funded by the rest of the world. And so you've got all these highly trained academics in China who are a bit frustrated because there's lots of money to do health systems research in China, but there's not so much money to do it externally. So I think what we really, in the first place, the long-term view is how do we support countries? And if it's not money, there's still exchange. It's easier than ever to communicate with people. How do we support researchers and scientists in countries to support institutions? That's what we're really focusing on. And so I think that will continue. And the long term is really for countries to lead themselves. And so the aid becomes less and less needed, right? And no country raises itself just by aid. I mean, it's really the country itself. But for people of goodwill like yourself who are still interested in support and working, and I think that's going to be the longer term challenge, right? Because it's going to be, I often say to members of my team, in Bangladesh, you can employ a PhD trained person for $8,000 a year, right? So when I look at my team and how much they cost, I say, well, how many Bangladeshi PhD workers are you worth, right? And I think the challenge for us so in global institutions based in expensive places or in countries that are higher income countries, what is our role in global? And I think that is going to change. And so I think I don't have the answer to your question. I think in the short term is that how can you maintain those relationships and help the people you know to whatever solutions. They have to work that out in countries, what they're going to do in their own countries in this acute crisis, and we need to support with ideas. But in the long term is what is our role in that change, in that evolution, in the way global health collaborations will occur, because that was going to happen anyway, and it's just been accelerated.
We're going to just take one more question, and I think over here.
Yeah, great. Super speech. Thank you very much. And I was heartened by your emphasis on equity. And I agree, equity isn't a bad word in Ireland yet, or still isn't. But actually, it's very hard to do equity research, or research with equity at its core. It's hard to do it, it's hard to get funded. So do you have strategies for how we as health system and policies researchers can further embed equity in our research? And also for the HRB and the government, how do you make equity politically acceptable to governments? Can you crack that one for me?
Again, we will finish with, and I know we have to move on, so I'll try and be brief. That's quite a difficult question. But it's really something I've pondered a long time, actually. And, so Mairead said I worked on the Commission on Social Determinants of Health, which was led by Michael Marmot. And I know Michael well, and he thinks I'm very negative, because I wrote this commentary 10 years after the Commission released its findings, which was 2008. So in 2018, I wrote this comment in The Lancet and basically said it was a great report, but we didn't achieve anything because nothing has changed. And Michael said to me, you're incredibly negative. Look at all these things that are happening. But I think my basic diagnosis is true, because I think that challenge you say to make a difference on equity we find very difficult, right? Because the way... And then, there's a counter-reaction now saying, well, actually, that's not the business of scientists or researchers, right? What I do think where there has been success is, I think the diagnosis and the data of the problem has been useful, but it's necessary but not sufficient. Where we've really struggled is to inform solutions. And obviously the rejoinder to that is, well, the solutions are political, right? They're not actually about not knowing what to do. It's just that people don't want to do them. But where, you can be very grim about equity, but there are a lot of lower and middle-income countries where health equity has improved over the last 20 years, right? Like places like Cambodia. And I think there are examples often where the ties talk about this thing, the triangle that moves the mountain. And what that is that to drive change, you need the three corners of the triangle, which are, yes, you need the knowledge, you need the researchers, you need the academics, but you also need the policymakers, the decision makers, you need government. But you also need the people, you need the social movements, you need civil society. And you need all three to come together to drive change. And so I think their answer to you would be, well, as researchers, how connected are you to the social movements, to civil society, to the policymakers, right? And I think that is something we've struggled. I mean, as someone who's been involved in social determinants work for a long time, we talk in this quite opaque language that is difficult to understand. And we do spend a lot of time talking about health inequities without necessarily engaging with the people who could make a difference, because we're not going to make a difference by writing papers even in The Lancet. Right? So I think the environment for that is going to get more difficult, right? We can see, but these things go in waves, and in the end, if you take the long view, the health equity has improved, over the last 100 years quite dramatically. So hopefully this is just a blip, and we still just need to do the work and do the good science, but really think how our work might act on the levers that might allow equity, which isn't just going to be about scientists, is with the rest of society.
I think we could spend the rest of the morning talking about all of this, but unfortunately we have to move on. Kumanan, that was absolutely fantastic. Thank you so much for your contribution.
Thanks a lot.